Hello, I'm Jack Militello, Professor of Management at the University of St. Thomas in Minneapolis, Minnesota, USA. I'm also the Senior Executive Fellow for the Center for Innovation in Healthcare Management. Thank you very much for having me speak to you today, and I'd like to thank Conrad Clark for the invitation. Unfortunately, I was unable to make the trip to Nigeria, and it was due to just an array of bureaucratic mistakes or holdups or whatever, and I think you'll all understand that. But again, I'm really sorry for not being able to attend the conference in person. I'm going to be speaking to you on my topic area, which is the overview of the American health system and what can be learned from it. Because it's not an interactive session, I'm not here. I have included my email at the end of the session, so I would field any questions that you have. So please feel free to email me at your convenience. I'd prefer an email to a text, because texts are usually too short. You'll see from this presentation that I may be a bit long-winded. So again, thank you, and thank you for having me. First of all, I want to talk about what the goals of the American healthcare system are. And these are pretty universally accepted. We call them aspirations. And most healthcare organizations adhere to these aspirations. And that's to reduce the growth in costs, to improve access, and to improve quality and service. I know that this conference is very much concerned with risk management and quality issues, and I will speak to them later on. But while these aspirations are acceptable by the healthcare community, they also have to be acceptable by the American public, which is, if you follow this in the press, this has been a struggle, or at least an adventure for American health policy. One thing to note about American healthcare is that it's a business. And probably more than any other country, we are focused on economic issues. We have economics, but also we have themes of wellness. And of course, when we talk about wellness, we also talk about them in economic terms. But the forces that really direct this business are government through health policy, and not only health policy from the laws that drive it, but also policy from the parts of the healthcare system like medical devices, pharmaceuticals, food, general well-being of the population, charities, and by these I mean charitable hospitals, and most countries are aware of the charitable hospital system they have. We have that in the United States, but it's also not for free. Again, it's funded through government processes, and the citizens fund their own way as well. Also, the charities have to make a living. They really have to balance their finances. So again, even the charities are looked on in business terminology. Lastly, businesses themselves. We have large established businesses. We have enormous insurance companies that run in the hundreds of billions of dollars in sales. We have hospital systems that go nationwide, systems like the Mayo and Cleveland Clinic and Kaiser Permanente, which are enormous systems. We have local systems that are large as well, like Mount Sinai in New York, or the hospital at University of Pennsylvania in Philadelphia, University of California, San Francisco. So we have big businesses related to health. We also have small businesses. We have startup companies. We have small clinics. We have doctors who are single practitioners. We have a lot of entrepreneurial organizations that are starting out looking at new sciences or ways to deliver service. So remember this as American. If you look at American healthcare system as different from other systems, it is a business. Yet, as a business, no one is left out. It's paid for by individuals. We pay for our system, and it varies individual by individual, need by need, location by location, and service by service. But we pay for our own way, at least in part. A good deal of the healthcare system is paid for by employers. Employers provide an insurance service for employees that cover a good deal of the costs, especially catastrophic costs. It's paid by state governments. The poor in states are governed. Remember, we have 50 states and Puerto Rico, so we have 51 governing units in our federation. And so state governments pick up the tab for the poor. And then we have federal government. And federal government subsidizes the whole healthcare system. But on the other hand, it acts taxes from the for-profit sectors. For example, in the latest law, the Affordable Care Act, the government has asked for a $40 billion tax from the medical device industry, which is to be paid over 5 years. So we have this paid for, and we make sure that everyone is taken care of in a variety of ways. Every municipality has a social safety net, has a hospital system that the government takes care of, that looks for the people who cannot pay. And likewise, our military veterans are covered by the Veterans Administration for the Army and the Department of Defense for the Air Force, Navy, and Marines. So again, we take care of our people, but at a cost. Now, what's the core of the healthcare system? And of course, we look at this as the doctor-patient relationship, and this is what you're looking at right now. So what feeds this? And if the system, and it'd be kind of simple if you look at this diagram, consumers behave a certain way, they take care of themselves, take their medicines, they eat healthily, they do a number of things to be okay. There's a number of tools, devices, pharmaceuticals, whatever. There's knowledge. We train an awful lot of people in the healthcare system. And we train doctors, needless to say, but also we train managers. And I'll talk about this near the end of the presentation about what we do in our healthcare MBA program. So we have a lot of knowledge. We also have a lot of research and a lot of analytics going to healthcare. And then we have the burden of illness. So we accept that as our core responsibility as citizens. Okay, that's pretty simple. Take a look at the next slide. To address this simple core system, we have an array of systems all over the place. And you'll see in an upcoming slide that this is 20% of our government business. If you look at India, it's 6%. If you look at China, it's 1%. So this is a huge part of the American gross domestic product. And you see all these different areas. If you take a look, there's environment, food, economics, employers, individuals, primary care doctors, medical clinics, and this goes on forever and ever. And we have most of our Fortune 500 companies in the United States are engaged in healthcare in some way or another. The big push right now is healthcare technology and analytics. Most of our firms are trying to get part of that. So when we look at the core delivery, we also look at all the regulations and stakeholders and participants in the healthcare system beyond that. And that makes it not only a business, but a complicated business. Now, let's take a look at these three aspirations. First, reducing the growth in costs. Now, if you take a look at this particular picture, we see that our healthcare business in 2015 is a $3.3 trillion business. And the projections of growth through 2021 are $4.7 trillion. This, again, is a huge share of our gross domestic product and growing. There's a fear that if this keeps growing, it's going to cripple the United States in terms of other investments and our foreign competitive position. Now, this has happened in the past. I mean, 100 years ago, farming was 60% of our gross domestic product. But new technologies come in forever and change that percentage. But we don't see that in the future. What we see is more and more investment in healthcare. And we see this as troublesome because this has to be paid for in some way or another. And we're not sure how that's going to be paid for in the future. So we're looking for ways to reduce that cost. Now, what are the reasons for the increase in cost? Improved technology. We have fantastic healthcare technologies being developed, not only in the mechanical end of it, but also in the diagnostic and delivery end. We're getting pretty good at solving problems. We have more and more sophisticated treatments, especially for end of life in areas like cancer that just take a lot of time and effort. We're getting more and more sophisticated. We're also becoming more sophisticated in treating children, treating rare diseases. On the flip side, we have an aging population. So as we get older, we discover different types of ailments for us. In fact, 80% of the cost of healthcare occur in the last 20% of someone's life. So the aging population is adding to the burden of cost growth. And if we get our population bubble right now, it consists of people who were born after 1956, which we call the baby boomers. And that's a large population bubble. And then we have a dip in population, followed by another population bubble. So we're going to have a continuous flow of aging populations discovering the need for new treatments. And likewise, the demand for more services. If there's a new technology in the works, people want to try it. Doctors want to be heroic. They want to give things a try. Our pharmaceutical companies are advertising, our medical device companies, our implant companies are all advertising to the public. So we're letting the public know that these services exist and that there's a demand for them. So these are the issues in rising cost. So how are we going to start attacking the growth in cost? And this slide shows the payment policy from the Affordable Care Act. First of all, we want to reduce the ICU attendance. We want to see how people can move out of those units as fast as possible. And given sophisticated treatments, improved technology, and the like, we're finding ways to move people through that system quite quickly. We also want to reduce inpatient hospitalization. In the past, that had been a boom for companies or healthcare organizations, especially the charitable hospitals. Get people in there, keep them for a few days. We want people in and out of hospitals. We're finding out hospitals are, if you look at risk, are dangerous places, but also very, very costly places. So we want to find ways to service people and move them out to their homes as fast as possible. And we've been very successful at that. In fact, in the Minnesota region, we've built a number of new hospitals and found out the hospital rooms have exceeded the need. We have 2 hospitals who are 400 beds each that have 50% of their beds unoccupied and what we call mothballed for future use. The push is more towards home health care and towards clinics, outpatient, ambulatory care, what have you. And now we want to drop intensive care, and we want to make ambulatory care a quick overnight visit. And again, with the increase in technology and sophistication of treatments, that's working as well. Routine hospital outpatient, we're trying to push the costs down to that. We want people to see their primary care doctor. We want them to engage in long-term care. We want home health services, which is a growing field. We're looking at prevention. Wellness programs are abounding everywhere. Even in the hospital systems, they're developing wellness programs that are keeping people out of hospitals. I should also mention technology in terms of the iPhone, which is a growing way to diagnose people. We're one of our hospital systems in Minnesota has an advertisement that says, be diagnosed from your couch. We're looking at the iPhone to connect us to certain things in our bodies that could be communicated to our physicians. Likewise, we're looking at kiosk medicine. Kiosk medicine means you could go to a pharmacy and have a blood taken by a machine, have the blood translated through a lab to your primary care physician that could come back to you electronically with a diagnosis. We're looking at also these walk-in clinics from retail stores. Even some of our bigger general retail stores like Target or Walmart have clinics where people walk in, are treated immediately, and they're treated usually by nurse practitioners or physician assistants. So again, we're trying to keep people out of the hospitals. We also have supportive communities. There are a number of stories of communities who have come together to solve a problem. I'll keep referring to my neighborhood or my neck of the woods here in Minnesota. There's a community that consists primarily of German immigrants that were very excited about beer and sausage, as well as smoking. One of our hospital systems put together a program called the Heart of New Ulm, and this is New Ulm, Minnesota. In the Heart of New Ulm, what they did, they said, let's get the community together to support each other, to reduce smoking, if not eliminate it, to reduce beer drinking, and they won't eliminate it, those Germans, and watch out for fatty foods, balance the intake of fatty foods. And this has been a community-based project where everyone joins together in this. Also, group exercise are very important. We brought the Surgeon General from Washington, D.C., the nationwide our nationwide doctor, let me put it that way, and she did exercise classes in New Ulm. So it's very exciting to see these communities develop something for themselves that are reducing the cost. So these are the ways or the directions that we're taking to address that huge cost burden. We do not want to see us going from 3.3 trillion to 4.7 trillion in the next few years. We have to keep our healthcare costs under control and keep that growth under control. We're also working on insurance reform, and the American insurance system is perhaps different than others. I've taken a look at insurance programs, and they're not really insurance as maybe Conrad Clark would describe insurance, or looking at risk management. They're really service organizations. It's interesting to note that when someone buys life insurance, there's no assumption of cashing in on it. Well, it's too late anyway. You're doing it for somebody else, and you may never use it. But same with car accident insurance. There's no way we want to use our car accident insurance. We don't want to cash in on it. On the other hand, we look at health insurance as something we're going to cash in on. And so it's not exactly an insurance program. It's probably a deferred service payment program. And we have enormous companies handling this kind of money, which is very disturbing for the providers and for the general public. We want to know, why those rates are so high, what's going on. And what we're trying to do now through our healthcare exchanges is to give consumers a choice among various insurance providers. We believe that giving a choice among those providers will allow our population to drive the costs down and be more reasonable. And we have what we call healthcare exchanges, and they promote price and quality competition. Now, we've been at this for 2 years, and if you've followed the American news on this, it's been a troublesome couple of years. A lot of the exchanges have not fulfilled their expectations, yet a handful of them, like from our state of Kentucky, state of Arkansas, Washington, D.C., have been remarkably successful. So we're looking to make sure these exchanges work, and there's a push to delineate the financial responsibilities through the exchanges from the employer. We believe that the employer coverage of insurance will be declining. So we have to manage risk. The costs are undetermined. As we know from risk management, you put a reserve for a future accrual, but as technology is going, and I mentioned the costs are growing, I don't know if we're accruing enough to handle the growth from 3.3 trillion to 4.7 trillion. We've narrowed our responsibility networks. We've put our insurance people we've put insurance in the hands of people that are long-term directed. when the healthcare laws were enacted, people were told they could keep their healthcare provider, but what was found out that many of the healthcare insurers just weren't good. They did not cover catastrophic long-term illness. And also we're expanding our state services for the poor, our Medicaid services. The problem is regional cost differences, and we're not sure why. Again, we're a republic of 50 states and Puerto Rico. We have our own insurance regulations. We have our own healthcare regulations, and they're not all the same. And we're trying to get rid of regional disparities. Why is a medical procedure in Boca Raton, Florida, or McAllen, Texas, far more expensive than one in La Crosse, Wisconsin? We believe it's because of the management in La Crosse, Wisconsin, far more sophisticated. Back to this idea of knowledge and learning, it's not equal throughout the country. And part of healthcare reform here is to equalize that knowledge so we could get rid of regional cost differences. Now, some of these may happen. For example, Boca Raton, Florida has an aging population, so they may be a lot higher in costs. A place like New York City might have higher costs because of the rent structure in New York City. So we can put those into account, but by and large, we want to get people on an even keel throughout the country. Insurance literacy is also very, very important. People don't understand what the deal is when they're dealing with their hospitals or their insurance companies. There's too much jargon, too much medical numbers and acronyms and whatever. We want to get people to understand clearly what's going on with their health and what's going on with their insurance situation. The United Health Group has put together, which is a large insurance company, has put together a health literacy program. And on their websites, they give people I think it's 4,000 medical terms and their definitions. Now, I think after a while, if you have too many of these, it becomes as much of a problem as as not knowing what any of them mean. But anyway, that's a key issue in health service. And as one of the issues that I was asked to talk about is how do you make patients more comfortable and provide better service? You should understand whether people understand. In fact, communication is very interesting. A lot of times professionals like you and me will communicate from our professional advantage. We'll tell people what we know about something, and we'll assume that they know what we're talking about. And we talk in initials and shorthand and what have you. Make sure people understand you. And I think that's a very, very key issue in understanding healthcare change. Put the power in the hands of people. Let them understand what you're talking about. The last point here is private exchanges. We feel that in the United States that the private market is going to drive down costs, and that if we get private exchanges that compete with government exchanges, that they're going to push the government exchanges to provide better and more economical services. So that's how we're trying to reform certain markets. And the insurance companies themselves are looking for 30 million new customers. And we don't know how this is working right now. It's sold on a state basis, which presents a problem for us because we can't. If you're working in a company based in New York, you get transferred to a company based in California. The insurance requirements are not the same. So we're trying to get a unified insurance system, which is very difficult. We feel that employers will start abandoning providing insurance. There's a penalty for doing so, but the penalty is far less than the cost of insurance. We feel that the larger companies will continue to support healthcare insurance, but the smaller companies will not be able to financially. And what we're seeing too is more of a retail-based customer orientation. Let the customer know what the terms are. Find places that they can buy it. Just like you have a choice of buying any goods or services, you do comparative shopping. Comparative shopping regulates the market. I have this note that insurance companies partner or buy providers to form ACOs. Those are called accountable care organizations. So what insurers are trying to do is what we call bundle services under an accountable care organization, under an ACO. So you talk about jargon, we all fall into these jargon terms. And the ACO is a way to share services. So if someone's coming in, we try to get the lowest possible service. So if a nurse can handle the issue, you don't have to pass it on to a doctor. If it can be done, if it can be done from more of a clinical perspective rather than a hospital perspective, that's pretty good too. So we look for people to work together to find the most economical way to do services. And as a note, the Mayo Clinic, one of our prominent healthcare systems, basically works from that notion of an accountable care organization. People participate, the doctors, nurses, managers, technicians, all participate in the diagnosis to come up with the best solution for the patient. So what are we trying to do with providers? What are we trying to do with doctors? We've reduced uncompensated care. And we're trying to determine that compensation, and this is troublesome, compensation tells you what the right care is. If it's non-compensated by insurance companies, the consumer ought to watch out and see what the doctor's doing, because a lot of times doctors will then ask the consumer to pay for this. We're trying to reduce the growth in payments, and this again is troublesome for physicians because they want their annual take to be larger each year, but we're trying to make sure that it's a fair compensation and that growth is not astronomical, that it's a reasonable growth year by year. We feel that forming larger groups and structures, mergers and acquisitions of organizations, will begin to create economies of scale. And with those economies of scale, we will have better cost issues, better cost reduction issues. Increased transparency and reporting. The more people understand what's going on, the more the bills are clear, well-defined, the better we'll do on reducing costs. For example, in hospitals, you may have someone coming by and taking your temperature on a regular basis. You only need to be done once. My own story here, and kind of my failure to get the paperwork in place to come to Nigeria, I had to check on my yellow fever shot to make sure it was current. I did not have access to my medical records. I had to go into a clinic. They measured my height, which they get a fee for. They measured my weight, for which they get a fee. They measured my blood pressure. All irrelevant. And then I had to speak to an international focused nurse to tell me about healthcare in Nigeria. All she did was run something off a website, which I had read, and then she told me that my yellow fever shot was current. So we went through all those cycles, those steps that were unnecessary billing. We're trying to reduce those kinds of things. And and they should tell me why we're doing this. And transparency would have said, you have access to your medical records. Now, there's new roles for healthcare professionals. I mentioned these ACOs, these accountable care organizations. They're teams. And we're looking to see our medical professionals working more and more in teams. And again, this is a regional issue. If you take service groups in places like Wisconsin, Minnesota, Iowa, the center of the country, they're very team focused. While you get in the peripheries, New York, California, Florida, they're more individual physicians. And we see that reflected in the costs. Informatics and robots are coming into play. And we're not replacing the doctor with robots, nor replacing judgment with informatics. What we're doing is using informatics and technology or robotic interventions to help the judgment of the doctor, to allow the doctor to focus more on the individual. And informatics talks about community health, helps us look at the community in a wider array. Robotics takes away some of the room for error in precision medicine, but we are not taking away the judgment of doctors. These are tools to help physicians do a better job. Consumers, and this is a push that we're really working on, is getting everybody engaged in his or her own health care. Of course, the way we do it in America, because it is a business, is we put more financial burden on the individuals. In the past, a lot of insurance was covered 100%. No one ever saw a bill, and you paid your insurance fee and never had to worry about it. Now we have deductibles. So people are knowing that the first $5,000, for example, comes from you personally. So you manage your contribution. You manage your own health. So if you reduce your health, for example, diabetics, if they work on exercise, food, work on their modest consumption, don't smoke, all these things will reduce healthcare costs, reduce the lab costs, reduce the visit costs, and people will feel better. And that's the push. And we're looking at areas like food reform. That our food companies are now reducing the use of trans fats. And I joke about trans fats and to say that a lot of the food we eat is not eaten by germs. It's food germs would not eat. We've been so concerned about production and not enough about consumption. And that's part of the push, is that we're looking at consumers taking a bigger shot at controlling their own health. We have an insurance mandate that everyone has to participate, and this is very difficult for younger people. We define them as the invincibles. They don't feel they're going to have any health care issues, and that's not going to be the case, and yet this is a social issue. We're looking for more responsibility from everybody, and then we need to make sure that primary care is accessible, and it's not always accessible. On the plus side, we've improved access to health insurance. Everybody has a chance to get into health insurance through the exchange. We are lowering healthcare inflation. I believe that this year the figures coming out from the government is that we're going to drop about 3 points from what we anticipated. So it's going to be it's still going to rise, but it's going to be a lower rise than the federal government had anticipated. So we're allowing entrepreneurs to come up with new ways to do healthcare and manage healthcare. And I mentioned here, I said the elimination of the job lock for entrepreneurs. In a way, the big organizations had stopped or had lobbied against entrepreneurs coming in with new ways to do business. For example, our pharmaceutical companies are now coming out with ways to market their drugs, which they hadn't been able to. There'll be availability of services in what we call pharmaceutical stores, drug stores. There's going to be a whole bunch of entrepreneurs coming into healthcare on the lower levels, ways to electronically access your health. Things like that are improving. Improve information about systems and provider performance. Now we're making doctors' records available. How could you pick a doctor to do something? There are websites and networks to go out and to address those issues and figure out who has the best service. And this is a threat to doctors, of course, but on the other hand, it tells the public who has the best reputation, who does the most procedures, who could I rely on, and even to the point to say who's closer to my home than can be. And so what we're doing is more or less coming up with giving the consumers control over their own health, which has not been part of the world of healthcare in the United States until the last 10 years. So the third point, so we had the first point was reduce cost growth. Second was the customer experience. Third is quality and safety. Now, U.S. Patient safety goals. We have a set of them. And these may sound, at least to the outsider, they do sound kind of mundane, but these are where safety issues occur. Identify patients correctly. Use identifiers, for example, name and age or date of birth. Apparently, there are a number of surgeries done on the wrong people, or procedures done on the wrong people, especially in our hospitals that are loaded with cases and people are doing numerous cases. This has been identified as a major problem. Know who you're working with. Use medicines safely. Label everything. Record and pass information. Take extra care with patient on blood thinners. Again, these are issues that have been identified as safety issues. So pharmaceuticals or drugs have been put in vials without identification. And granted, every pill has its own color and shape, yet that's missed on occasion. So one of our safety goals is to label everything. Use alarms safely. Equipment alarms, when they misfunction, are often ignored, especially in noisy operating rooms. Make sure that safety alarms are heard. Fourth, prevent infection. Again, as an outsider, this seems so simple. Use hand cleaning guidelines. Wash your hands. One of our prominent healthcare systems in Minnesota actually put together videos for doctors to wash their hands. You'd think that this would be normal procedure, but this is what we're looking at as key safety. Clean catheters. Prevent infection, keep things clean. It's interesting that a study was done recently about safety in restrooms in hospitals, and it was found that elderly patients have difficulty looking at white. And so when the lights are on, they may fall over a sink or something. And so the consultant who did the study recommended that every restroom be painted different colors. And this is a huge pushback. They said, no, colors hold germs. White, smooth surfaces are the cleanest surfaces we can get. So other measures for people falling will have to be taken. But this is, cleanliness is very, very important for all this. Prevent mistakes in surgery. There are many, many mistakes, in surgery, and it's an easy thing to say prevent mistakes, but some of the guidelines said mark on patient where the surgery is to be done. Again, there's been wrong side of the body surgery done. And we found in the United States, and this has been corrected, if you studied at Stanford University and you're going to be working on a knee, you mark the knee you're going to work on. If you were studying at New York University and you're working on a knee, you marked the knee you weren't going to work on. So even across the country, we had different standards of marking patients for surgery. Make sure it's correct. And make sure the correct surgery is being done. And this sounds, again, as an outsider, kind of silly. Ask the patient. What are you in here for? What's your expectation? And that goes back to some of this health literacy that we're talking about, is that ask the patient. So those 5 are the key guidelines for the United States for quality and safety. But let's take this a step further. In Minnesota, our healthcare organization has its own guidelines, and they're hinged on this notion that safety is a team effort. I mentioned this before about teamworks and ACOs. Minnesota says leadership, set safety expectations. So someone on the healthcare team has to set those expectations. Who's in charge? Who's responsible for safety in a patient? Is there someone in the provider team that said, that's my responsibility. I'm going to make sure that all the safety procedures are followed. Communication. This should be everyone knows what's going on. Everyone should know what's happening. Everyone should be prepared and expect the procedures to be followed in a certain way. Teamwork makes the process more effective. You know, we don't want doctors yelling at nurses in emergency rooms or in operating rooms or throwing things or whatever. I mean, understand this is a team effort. The surgeon's in charge, yes, but still a team effort, and everyone has a role to play in the effort, and those roles ought to be respected. Learning. Report errors and successes. And this has been a big push through the Institute of Health Improvement. Reporting errors. None of us want to report errors. That's a blight on us. But that's the way you learn, is you report what went wrong. And then you could figure out what to do better next. Likewise, report successes. What things have you figured out? What have you done that's worked well? How do you report those out? How do you share both the error and the successes with teammates and with your colleagues? Patient engagement. I've said this before and I'll repeat it again. Make sure that patients are health literate. This could be one of the best safety issues you could have, is work with the patient. Have the patient be a guide for you. Let them know what they expect, and they could tell you what's right or wrong, what's going on. And this is antithetical to a lot of healthcare or physician-directed behavior. The physician's in charge, still in charge, but make sure you get information from the patient and make sure the patient has a handle on what's going on in the process. So that's the patient experience is another part of this process. And it was an interesting dilemma that healthcare organizations have, because they don't call patients customers, and they wonder what this experience means. Just recently, here at the University of St. Thomas, we had a workshop that had project managers from a local set of clinics, and we had people from the target retail area. And when you say, well, and the people from the clinic were asking the target people how to enhance the patient experience. And these were some of the issues that came up. And I know, Joachim had asked me to include some comments about how to make the experience better. And this comes from this workshop we had. Can patients find you? That's very interesting. Are you easily accessible? Do they know where you are? And even once they get to your hospital or clinic, can they find you within the clinic? Is your place clean and attractive? Take a look. I think back to a number of issues. Again, Joachim asked me to talk about some experiences I've had with other countries. The worst I've ever seen is India. And I was in Bhopal, and I actually went into the operating room, and it was not clean and attractive. But also the one elevator that brought people into the examining rooms was the same elevator used by citizens coming up and down to visit family. The front door of this particular hospital had shotgun guards. Not clean and attractive. I've been to Kuala Lumpur. The public hospital, the charitable hospital, is run down, a fence to get in. It takes forever to get there. The for-profit hospitals are clean, attractive, bright. You want to be there. Vietnam, to get through the Vietnam patient experience is incredible. It could take you a full day just to be diagnosed with an earache. They don't make it attractive. They don't make it easy to get to. They don't feel well serviced. And this is because the doctors and nurses do what's good for them. And the target people say, do well for what the patient wants. No waiting lines without information. You can't always serve people 100% of the time. But one of the problems with waiting is people feel, did they lose me? Will I get my turn? And there has to be some information to let people know that they're in a queue and they're working forward. Are they informed about procedures and results? Do they know what to expect, and do they know what happened? Back to health, are they healthcare literate? And these are some models or ideas that came from this idea of retail. So, if nothing else, you might want to take a look at your own system delivery and say, are you a customer-focused delivery? You could still call them patients, but in your own mind, when you're assessing who you are and what you are, think in terms of them as customers. Or even better, think of you going through this. Think of you being serviced, your waiting line, your attractiveness, your ability to get someplace. All these things are very, very key to the health of the citizen, is to feel that they're well served. Okay, so that's kind of the broad-based look at the United States. And what are we trying to do here in terms of an MBA program? What an MBA teaches a doctor? Joachim had asked me to mention this about MBAs. It's not about gaining finance acumen or becoming wealthy or finding new jobs, whatever. As we mentioned earlier, healthcare is complicated. It's a complicated business. And we're most likely to be able to learn our way to success. And that's what we're looking for. We're looking at how do we get out of this complicated quagmire? How do we make sure that we're not going from $3.3 trillion to $4.7 trillion without some sense of goals and objectives? And what does an MBA do? Well, you know the numbers. And that becomes important. You know the strategy, finance, and accounting. You know those things that fit into the business model. Because again, if healthcare is a business, you better know the terminologies of the business. Know the risk. And this is economics and operations. You're here for a risk management conference. You can't mitigate all risks, but you have to prepare for those risks. But through economics, you could prepare for the risk, and through operations, you can mitigate. You could find out where the weakness in the system is, what isn't working, where you did cause errors, how processes aren't followed correctly. So those could help you. Know how to serve. I just went through this notion of dealing with retail. Know how to serve. Understand what marketing is. Understand that your patients are there for you to serve, and you should be welcoming the ability to serve them. Understand their behaviors. Why do they come to you? Why don't they come to you? Why are they reluctant to talk to you? Why don't they take their medicines? Why are they repeat performers? All these things have to be understood in terms of human behavior. Know how to influence others, and that's leadership. And we're not influencing patients, we're influencing the system, influencing your colleagues, influencing the people whom you work with. All these things are important for understanding the overall concept of healthcare management. And going back to earlier slides about the complication of the system, what we try to teach people in our healthcare program is how to deal with these complications. You're not going to eliminate the mess. There are always going to be messy problems. But as we get better at dealing with them, the mess becomes reduced. When the mess is reduced, we address those three aspirations. The growth in cost will stop. Our quality and safety measures will go up in terms of in a positive way, and our patient experience will also be increased. So those are the kind of things we teach in the broad basis of an MBA program. So with that said, I'll conclude at this point. I know there's a lot of information. I guess unfortunately I'm not there, but fortunately it's electronically available to you, and hopefully there'll be issues that you'll want to chat with me about. I have included my email, as I mentioned at the beginning of the presentation. I prefer email to text. Text is too short in terms of responding to some of these things. But if you have a question, please feel free to email me. And also, again, I would like to thank Conrad Clark and Joachim for for inviting me and to apologize deeply for not being able to attend the session. So good luck with the rest of the session, and good luck with your practices.